terrible bedside manner. Terrible. She weren't even looking at him during that bit. Hi, my name's Dr. Amir Khan. I've been an NHS GP for the best part of 15 years, and I am here to break down some TV and film clips about doctors to tell you what is real and what might be a bit of a stretch.
Dr. Jacobson?
Yes?
We need you urgently in OR3.
No, can do. I'm doing number 4 at 1.
Sir, it's urgent. We have a ruptured kidney and massive bleeding.
Okay.
Right, this always happens in hospital dramas and TV shows where nurses or clinical staff come rushing out and give all this confidential information away in the corridor. That is not true to life. We are not allowed to do that.
He's got a penetrating injury to the left chest.
Yes.
Now, in my experience, when I'm in theatre, the theatre staff didn't help me gown up. I would have to do all of that myself because it has to remain sterile, so no one else apart from you is allowed to touch it. And you're supposed to wash your hands and your arms and your elbows before you get to that stage.
Shall I extend the incision, sir? We've taken it from the breastbone to the diaphragm. We may have to...
So he said there he's taking the incision from the breastbone to the diaphragm, and they actually are in the same place, just here. So that would make the incision about this big, which would not be big enough to take a bullet out or to explore an abdomen to find a bullet and take that out.
You're right, doctor. We should wait for the x-rays.
You'd expect them to have had the x-rays already before they even thought about doing surgery. It's probably an MRI or a CT scan that they really need. Now, one of the most disappointing things that happened to me while I was at medical school was when you have to shock someone. Now, I'd only seen it on telly like this, and you see them kind of jump up out of the bed and then back down again. That does not happen. They do not even move when you shock them. There's no jolting up and down. I was like, are these things on? What's going on? But they were on, and it just doesn't happen in real life, which is such a disappointment, isn't it, really? I know this is Mr. Bean, and it's Mr. Bean, but taking a bullet out, A, wouldn't be that easy, but also it would probably cause more bleeding, so they would have to take it out and then stem the flow of bleeding. It wouldn't just be a case of taking it out and then the heart suddenly comes back to life. If only it was that easy. Now, that was Mr. Bean. I love his movies. We always watch them as a family, but I don't think they should be taken as factual. Definitely more on the comedy side. Lots of errors in that clip, but it was good fun. Accuracy rating on that one, I'm gonna have to go low. I'm sorry, Mr. Bean, but 1 out of 10, I can't think of really anything that was accurate there, but funny.
Your role is to talk Gallinger through the procedure, nothing more.
Nice to see washing hands. You don't often see that on television because it's a bit boring, isn't it? But at least they're scrubbing in properly. That brown stuff is iodine, which we often use for sterilising things, including our own skin.
Nurse Pell, pulse, please.
It's weak at 110.
Now, this used to happen. So this is why operating theatres are called theatres, because they used to do the surgical procedures in front of an audience, usually made up of clinical students, medical students, perhaps even nursing students, but back then it was mainly just male medical students. So that's where the word theatre comes from when we say, I'm going to theatre. It doesn't mean the West End, sadly.
Death by exsanguination is a risk, but once inserted correctly, the clotting properties of the galvanic wire will likely halt the danger.
So the aorta is the big blood vessels that runs really right down the middle of all of us, and off it comes all the branches that feed off to the other organs. And if you rupture that, or if you nick it in any way, you are on a hiding to nothing. You are like literally going to die because you'll just bleed and bleed and bleed and bleed. So whatever he's doing, if he's going to make an incision in the aorta, he needs to stop the bleeding. And he referred to that, but I'm not quite sure how he's going to do it.
The aneurysm is beginning to clot and harden.
Looks like it's Mr. Gacho's lucky day.
I'm not sure about what's going on here because they keep referring to an aneurysm that's about to clot and harden, but an aneurysm is a widening of a blood vessel and it weakens the blood vessel, so there's a risk of bleeding. You don't want to cause a clot anywhere inside of a a blood vessel, certainly not around an aneurysm either. So I'm not entirely sure what kind of surgical procedure they're doing. So that was the Knick, depicting 19th century surgery. I think what was interesting there was the setting, really, the fact that people used to watch operations like that in a theatre, essentially. My accuracy score on that one, because I wasn't quite sure what they were doing, because they didn't make that too clear, but the setting was certainly very realistic. So I'll give it a 6 again for that.
This is the same gallbladder, and here we can see the small object has become dislodged and is now down here. This is what I like to call the Mick Jagger effect, because it is essentially a rolling stone. Which is a joke, you may laugh.
I like that joke. Stones do move. They don't tend to roll. They kind of get squeezed along tubes like this. But yes, stones can move along the ducts that attach to the gallbladder and cause all sorts of problems, including pain, infection, jaundice. So I'm going to steal that joke for next time I see a gallstone, I think.
You will find it funny.
I doubt it.
I remember ward rounds as a medical student, and most of them were lovely. Every so often, you'd get a scary one, and you'd be round a patient's bed, and you'd say, right, what's wrong with this patient? And you'd have to just look at them and tell them what's wrong. And if you got it wrong, you were in trouble. So I think there's an element of truth in the consultant and the medical student kind of dynamic. But I've never been poked by a consultant. Accuracy-wise, I'm not sure there was much medical content here, but the joke was funny. We don't get poked, but we do get told off by consultants. So 7 out of 10, I think.
Difficult.
Sometimes I do this. When I go and visit a family or friend in hospital, I can't help myself. I have to look at their charts at the end of the bed and see what their blood pressure and pulse and everything is doing with their permission. And then they want like a full breakdown of how they're getting on. So yeah, it's easy just to see that chart and flick through it, I think.
You know, I noticed that someone wrote in my chart that I was difficult in...
We don't tend to write that about patients. To be honest though, they used to, like years ago. So sometimes when I pull out paper records of patients to look at things that might have happened to them a while ago, you can see what old school GPs might have written about a patient, and difficult is something they may have said, or something even perhaps worse, but we definitely don't do that now. And patients have access to their medical records online, so we'd be silly to write anything personal like that, and you shouldn't do.
How about if I just erase it? Now, about that rash.
But it was in...
We can't change medical records once they've been written. That's like a big no-no. Again, it's one of those sackable offences. Don't change medical records.
Let me just review your history before we begin.
Oh, where did you get my chart?
From your last doctor. Standard procedure.
Medical notes follow you around wherever you go. So if you ever have to be in hospital, you'll see a new patient's note starts off really thin, and then over time, if they have repeated appointments, it gets thicker and thicker and thicker, and everybody adds to it. And so some patients have 2 or 3 files, but they will follow them around wherever they go. And it's really important that we look at their past medical history. Now things are digital, it's a bit easier, but we still have to go back to the paper records occasionally. So that was an episode of Seinfeld. It was supposed to be describing a difficult patient, but I think she had some valid points there, and she seemed nice enough. Accuracy-wise, I think doctors are a bit more empathetic than the ones we just saw, so I'm going to give it 5 out of 10.
Hello. Sorry to keep...
I want to be one of those doctors who wears something around their head, whether it's a light or a magnifying glass, but unfortunately, those things have gone well and truly out of fashion, and if you need a light, you just switch it on.
Murray Kaplan sends his best.
Not sure where this is taking place, but there's a lot of televisions. Don't know whether it's a surgery or a electronic store.
A tickle, I've been hoarse. So
if someone came to see me with a hoarse voice, I probably wouldn't stick my fingers inside of their mouth and start rubbing their gums, because I'm not quite sure what that would tell me. And I'm not quite sure whether this lady is a doctor or a dentist, because she seems to be a bit of both. And we're very separate professions. I know nothing about teeth. But if you're watching this, and this is serious, if you've had a hoarse voice for 3 weeks or more and it's unexplained, perhaps even if you're a smoker, very important, go and see your doctor, because that could be something serious. It could be, might not be, but it could be. So 3 weeks or more of a hoarse voice, go and see someone about it. When you're examining someone's glands, you're supposed to go around the back of them so you can get a good feel all the way round. So what she's doing there is something called tracheal centricity. So your windpipe that goes down there, sometimes if there's a problem in either one of your lungs, it can get pushed to one side. So you have to make sure it's central. But she's been a bit rough, to be honest.
Whoa, a periscope.
Won't be pleasant.
So if you're going to do a procedure like this, the best thing to do is explain to the patient what you're doing and why you're doing it. I wouldn't just pick up random bits of equipment and tell them to open up their mouth and not tell them what I'm going to do and just say, it'll be a bit uncomfortable, and expect them to get on with it. They need to be fully informed and on board.
Doctor, you have a growth.
When you're breaking bad news, be a bit gentler, I would say. I always liken it to taking people down a flight of stairs, one slight step at a time, give them a warning shot, another warning shot. This woman has just pushed this person down those stairs without really giving him any warning shots.
I have to check with my secretary, but if it's remotely possible, I'd like to do a biopsy tomorrow. Okay?
Terrible bedside manner, terrible. She wasn't even looking at him during that bit. So that was a scene from The Doctor, and I've got to say it was pretty terrible. That lady had no bedside manner, her communication skills and examination skills were really poor, and that poor man was left wanting, I think. So accuracy-wise, I'm going to give it 3, I think, out of 10. Thank you for watching. You can get my new book, The Doctor Will See You Now, in hardback and audio by clicking on the link below. And don't forget to subscribe to Penguin by clicking on the link here for more videos like this.